Welcome to Virtual APSA 2021. This is the medical student poster session, and we are very excited to present 10 posters today. My name is Dr. Jill Whitehouse. I am a pediatric surgeon at the Joe DiMaggio Children's Hospital in Hollywood, Florida.
And I'm Dr. Christian Walters at the Children's Hospital of Georgia.
And I'm Dr. Anthony Stallion at Beaumont Children's Hospital.
So Dr. Glick will introduce the first presenter.
Our first abstract will be presented by Toby from Penn State College of Medicine. Her presentation is entitled Core Needle Biopsy is Safe, Effective, Yet Underutilized in Diagnosis of Pediatric Solid Tumors.
My name is Toby. I'm a third-year medical student at the Penn State College of Medicine. I'm honored to share with you all the work we're doing to evaluate and standardize core needle biopsy in pediatric patients with solid tumors. Core needle biopsy is recognized as a safe alternative to open surgical biopsy for children with solid tumors, but is not a widely adopted practice. With the ultimate goal of standardizing solid tumor biopsy at our institution, we aim to track diagnostic yield, the number of subsequent biologic tests performed, and tissue banking yield following core needle biopsy. We hypothesized that core needle biopsy would be as safe as open surgical biopsy. We conducted a single-center retrospective analysis of the last 48 consecutive tumors biopsied at our institution over a 5-year time span from September of 2014 to January of 2020. Only abdominal and retroperitoneal tumors were included. Neuroblastoma and hepatoblastoma were the most common tumors biopsied by core needle. Patient weight and tumor volume were comparable between groups. Tissue yield was adequate to make the diagnosis in all cases in both groups, but there was significant heterogeneity in the number of core biopsies between interventional radiology providers. Tissue banking yield was also low, with only 38% of all biopsy patients being consented and only 18% of consented patients having enough tissue to be banked. While ability to yield the diagnosis was comparable, open surgical biopsy led to higher rates of complications, with need for post-procedure blood transfusion being the most common. Our data suggests core needle biopsy is safer, but heterogeneity in sampling and lack of tissue banking suggests a need for standardizing tissue utilization. Our next step is prospective analysis of similar metrics with the goal of closely following the utilization of tissue after collection. We ultimately hope to establish an institutional protocol that more carefully tracks tissue use and facilitates higher rates of tissue banking and ancillary testing of pediatric solid tumors. Thank you.
Thanks, Bannon, for being here. It's a timely project that you guys did. As you know, there was a recent PSORC study that addressed this issue specifically with respect to neuroblastoma only and came up with similar conclusions. However, in that study, they included the ability to obtain molecular traits like McN, LOH, and ploidy, which are important for risk stratification. Did you look at this for your neuroblastoma patients?
Thank you for your question, Dr. Glick. We did take a look at that for our neuroblastoma patients, and for all of our patients with neuroblastoma, we made sure that the tissue samples taken allowed them to have eligibility for COG trials. The problem we identified, which is what kickstarted the prospective arm of our study, is that our pathology department only started documenting specific use of tissue samples in 2015. So we were unable to identify whether those things were tested in any patients prior to 2015.
I got it. Okay, because that is an issue, as you know, for cores, and that was found in the PSORC study as well. That same group in their project showed that a pathologist being there at the time of the percutaneous biopsy increases the diagnostic accuracy, and I found that in our institutional experience as well. Did your team assess for this, and do you think it would be likely in your protocol as you put it together to do this in the future?
We reached out to our interventional radiology colleagues and our pathology colleagues to ask the question. And it seems that while they prefer to have a colleague present, it's not currently standard to have one present. So that is something that we're hoping to incorporate into the prospective trials moving forward.
Yes, I think it is very important. Well, thank you very much, Bannon, for the presentation. It was excellent.
Thank you.
Our next abstract will be presented by Jennifer Crook from St. Jude's Children's Hospital. Her presentation is entitled, Why Do Ports Get Stuck? A Case Control Study.
Hi there, my name is Jennifer Crook, and I'll be presenting on our institution's investigation of Why Do Ports Get Stuck? A Case Control Study. So we all know that subcutaneous ports provide durable central venous access, but at removal, some of these ports are stuck and require additional measures. And if catheter fragments are retained, long-term surveillance is necessary. We noticed a cluster of stuck catheters at our institution among those with hematologic malignancies, so decided to investigate further. We tracked port placement between April 2014 and September 2017 using an a priori definition of difficult removal. And those difficult removals were then defined as cases and paired with gender and age matched controls at a ratio of 1:3. We also collected additional clinical variables such as diagnosis, duration of port indwelling, port manufacturing information, agents administered through the port, and others. So we ended up tracking 57 stuck port cases and 171 age and gender matched controls and found significant associations of having a stuck port among those with a diagnosis of acute lymphoblastic leukemia, a longer indwelling duration of the port, a polyurethane versus a silicone catheter, subclavian access, and placement by a surgeon versus an interventional radiologist. Then we conducted a multivariate analysis and found that diagnosis of ALL and the longer indwelling duration of the port remained significant after adjusting for other variables, but the type of catheter, the access point, and the specialty of the placing physician did not remain significant after we adjusted for variables, including that diagnosis of ALL. So what can we conclude from this? We saw that ports are more likely to get stuck in patients being treated for acute lymphoblastic leukemia and in those with longer indwelling durations, polyurethane ports, subclavian access, and placed by a surgeon rather than an interventional radiologist. However, those increased odds of becoming stuck that were associated with catheter type, access point, and physician specialty are no longer significant when adjusted for a diagnosis of ALL. So we concluded that central venous catheters placed for long durations in the treatment of ALL may become difficult to remove and warrant further discussion of risk and appropriate preparations for removal. Thank you for your time.
Thanks for doing a project on this topic. This is a problem frequently encountered by pediatric surgeons. It's often horrible to find yourself in the middle of an operating room with what was supposed to be a very, very quick case, and then starting to sweat as it becomes a big ordeal trying to get a port out. It sounds like there are two main factors that truly played a role, which were the diagnosis of ALL and the longer time having the port been in place. Were these two completely independent of one another? I ask because ALL patients typically have some of the longest indwelling ports.
Yeah, so on multivariate analysis, we did find that both that diagnosis and duration of port placement were independent of each other and in evaluating if it was going to get stuck.
The project was done on patients with hematologic malignancies. I'm wondering why you selected out that group specifically rather than just all patients who have metaports.
So we actually looked at all patients with ports placed from April 2014 to September 2017 and age and gender matched the patients who had stuck ports at a controls to cases 1:3 ratio. Only half of our study population actually had hematologic malignancies, but 95% of the stuck ports were in hematologic malignancies.
I gotcha. Do you guys have any hypothesis as to why the ALL ports have these issues? Does it have anything to do with that funny calcified layer sometimes we find?
So our main hypothesis as to why ALL ports are the ones getting stuck is that it's a combination of the longer duration of indwelling and the chemotherapeutic drugs that we're putting in through the port. And we do typically see a calcified layer on those stuck ports in addition to a rough and yellow catheter surface, as opposed to the smooth, bright white, naive surface that we see when we put it in.
Right. Well, thank you again for the presentation. It was fantastic.
Thank you.
Our next abstract in this session will be presented by the newly graduated Dr. Mikhail Quattrone from the University of Kentucky. Her presentation is entitled Injury Pattern and Outcomes Following All-Terrain Vehicle Accidents in Children.
Hi, my name is Mikhail Quattrone. I'm an MS4 at the University of Kentucky, and today I'll be presenting on injury patterns and outcomes following ATV accidents in children. Multiple medical associations have highlighted the risk of ATV use in children. Despite this, ridership, injury rates, and fatalities remain high in the population. Kentucky currently rates second per capita in fatalities in the United States. Because of this, our study goal was to provide a descriptive analysis of ATV accidents in order to identify injury and potentially unsafe riding patterns. This was a retrospective review of children who presented with ATV-related injuries to a single level 1 trauma center from 2006 to 2019. The children were grouped into 3 age-based categories based on current state ATV laws, and injury patterns and outcomes were analyzed based on helmet use and age. In total, there were 720 patients included. Of those, 71% were male and 82% were not wearing a helmet at the time of injury. The most common injuries were extremity fractures and head injuries, and there were 7 total fatalities. Compared to those who were wearing a helmet at the time of injury, those without helmet use saw a 2-fold increase in head injury, as well as a 2-fold increase in intracranial hemorrhage, and had a lower mean GCS on arrival. Additionally, when stratified based upon age, those 16 and older were less likely to wear a helmet and saw higher rates of head injury, intracranial hemorrhage, and severe TBI. The older children also saw a higher median injury severity score and were more likely to have severe injuries. Based upon these results, we conclude that ATV accidents result in serious injuries among children in Kentucky. The majority of children hospitalized in our study were not wearing a helmet at the time of injury, despite that state law mandates helmet use in those less than 16 years of age. Additionally, we found that children 16 and older were most likely to be severely injured. And this is the current age group least protected by current state law in regards to helmet and engine size regulations. Both of these highlight the opportunity for both improved helmet education programs as well as increased state safety regulations, particularly within the older pediatric population. Thank you, and here's my contact information.
So thank you, Dr. Quattrone. The invited discussant for your paper is Dr. Christian Walters from the Children's Hospital of Georgia.
Thank you, Dr. Quattrone. Your presentation was excellent, and it really struck a chord with me as the lack of helmet use is something that we struggle with also with our pediatric patients here in Georgia. I only have one question, and it is, what, if any, programs for helmet education do you currently have in place, and how do you plan to modify it in the future to hopefully increase helmet use in this vulnerable population? Again, I really enjoyed your presentation, and I look forward to your response.
Thank you so much for the kind words, Dr. Walters. Currently, we do have a helmet education program in place for bicycle usage, which also provides helmets to those participants. There currently isn't one in place for ATV use, which is in a large part is due to the lack of funding and the difference in helmet costs between bicycles and ATVs. However, based on our current research and results showing that most of the pediatric patients we saw weren't wearing helmets, we're now in the process of applying for funding and the hopes to be able to start this type of programs. We were also able to capture data, which I didn't include in this abstract, looking at geographic locations and county accidents within Kentucky. And we're hoping to use that data to be able to start some outreach programs to be able to reach those more rural counties where we're seeing a lot of ATV accidents from those pediatric patients. So we're hoping to start doing those things in the future to try to increase the education and hopefully start to prevent some of these injuries in Kentucky.
Thank you, Dr. Quattrone and Dr. Walters.
Thank you.
Our next abstract will be presented by APSAsode from the Medical College of Wisconsin. His presentation is entitled Vomiting Babies in Gastric Antral Web, a Missed Opportunity for Surgical Intervention.
Good evening. My name is APSAsode, and I am a third-year medical student at the Medical College of Wisconsin. Today, I will be talking with you about vomiting babies and the gastric antral web. So among the various types of etiologies for vomiting, we have the gastric antral web, or GAW. GAW is a prepyloric mucosal redundancy as shown in these images. You can see with my pointer that it's this web right here. It can be treated surgically by open or laparoscopic resection of endoscopically marked web. The purpose of our study was threefold. First, to identify clinical and endoscopic features predictive of successful surgical intervention in GAW patients. Second, to create and use a classification system for postoperative AWRP patients, that's in antral web resection and pyloroplasty patients. And third, to assess early outcomes of AWRP on emesis, FTT, and post-pyloric feeds, FTT being failure to thrive. So we identified 40 patients, median age of 15 months, who had undergone antral web resection and pyloroplasty. We classified them according to vomiting status and Z-scores into 3 categories: responders, partial responders, and non-responders. The results are shown here. Of note, 68% of patients showed some improvement post-op, that is responders and partial responders. When responder status was matched to preoperative clinical features, age, upper UGI, emesis, and FTT were notable for having a high percentage of patients showing improvement, meaning they were classified as responders or partial responders. And in this graph, we see that weight gain is represented by increase in Z-score at follow-up. Responders had the greatest increase in median Z-score, then partial responders, and non-responders had a decrease. So in conclusion, gastric antral web is a cause of vomiting and failure to thrive. Treatment is surgery. Outcomes depend on patient selection. We found that they depend on vomiting, age, FTT, and abnormal UGI. Next steps are matching endoscopic anatomic features to surgical outcomes. These are our references, and thank you for listening.
Thank you, Mr. Syed. The invited discussant for your paper is Dr. Anthony Stallion from Beaumont Children's Hospital.
Well, Dr. Syed, thank you very much. I really enjoyed your presentation on an interesting topic. I have two questions for you. Given the variable results of the procedure, how can you be certain that there was actually a symptomatic antral web and not poor gastric emptying that was improved with the pyloroplasty? And my second question, for non-responders to what should be a remedy to a mechanical obstruction, are you sure that the antral web was actually the etiology of their vomit? And again, thank you for your presentation.
Okay, so for your first question, in general, vomiting has many etiologies. Aside from anatomic, we have physiologic, functional, and even like behavioral. So when we were selecting these patients, out of a pool of many patients, we identified only those that we were really certain that would need surgery. And so going with that, we were thinking that the anatomic features, the upper GI series showed fairly significant antral webs. So from there, we were thinking that that would be the main issue. I mean, gastric emptying could also be a cause of the vomiting and the symptoms, but that's like part of our next study to actually find endoscopic anatomic features and line them up more closely with the post-surgical outcomes to see that whether a certain type of antral web has more likely of a beneficial outcome, or whether some type of antral web should better be left alone. In regard to your second question on non-responders, it may be that after the resection, we need to wait a bit longer to see any results. If we still do not see any results, it might be another cause of vomiting, as we discussed in the first question. One of the causes might be gastroparesis, that it may have developed before the resection, so we might have waited too long for symptoms to develop, and in that case, gastroparesis developed. For that, we would need to undergo gastroparesis treatment.
Our next abstract in this session will be presented by Radek Bus from the Medical College of Wisconsin. His presentation is entitled Barriers to Same-Day Discharge After Appendectomy for Uncomplicated Appendicitis.
Hello, I'm Radek Bus from the Medical College of Wisconsin. Thank you for the opportunity to present our work. In this particular study, we investigated potential barriers to same-day discharge after appendectomy for uncomplicated appendicitis in children. The objectives were to compare outcomes and resource utilization based upon the use of same-day discharge and to identify the contribution of various factors in determining the use of same-day discharge. We hypothesized that same-day discharge would reduce resource utilization, and patients who undergo appendectomy later in the day, as well as those who live further from the hospital, would less likely be discharged on the same day. Associations among the variables of interest with same-day discharge were evaluated using multivariable logistic regression models. Travel time and neighborhood level socioeconomic disadvantage, as marked by area deprivation index, were determined from patient home addresses. In Figure 1, you can see that same-day discharge has increased significantly over time, approaching 42% in 2019. Table 1 confirms previously reported findings that same-day discharge leads to decreased hospital charges, median difference of $2,000, and lower postoperative length of stay with median difference of nearly 14 hours, without any increase in adverse outcomes. When adjusting for other variables, same-day discharge was less common among children from more disadvantaged neighborhoods, with the likelihood decreasing by 9% per decile increase in ADI, as well as those with later time of operation. Compared to surgery before 12 p.m., those with surgery between 12 and 5 and after 5 p.m. were 78% and 99% less likely to be same-day discharged, respectively. Interestingly, travel time did not have a significant impact. Finally, among patients admitted overnight, earlier surgery increased the likelihood of same-day discharge. 35% of those who underwent surgery before 12 p.m. were same-day discharge, but only 13.5% and 12.5% were same-day discharge if their surgery was between 12 and 5 and after 5 p.m. respectively. In order to increase same-day discharge and maximize the value of surgical care, systems should address socioeconomic impediments to timely discharge, prioritize early appendectomy after overnight admissions, and facilitate same-day discharge even when appendectomy is performed later in the day. Thank you.
Thank you, Mr. Buss. I will be your discussant today. I really enjoyed your paper, and as a former fellow at the Medical College of Wisconsin, it's very exciting to see the changes and the progressive nature that is being taken there. My question for you is, how long was your average PACU length of stay in the ones that were successfully discharged on the same day? And did those times vary depending on when you did the surgery? So for example, did an 8 a.m. API stay for 4 hours, whereas a 3 p.m. API only stayed for 1 or 2 hours?
Thank you. So we actually did not closely evaluate the length of stay in the PACU. However, in our postoperative pathway, patients usually stay in the PACU for only about 30 minutes to an hour before returning back to their inpatient floor rooms. And that's for both groups, those that are discharged on the same day and those who will potentially be staying longer. So both groups will be returning back to their inpatient floor room after surgery. So the length of stay in the PACU should not really differ based on the time of the day either then.
I see. Okay. And did your postoperative pain management strategy differ between those that were successfully discharged and those who stayed? So for example, if someone stayed, did you put them on IV narcotics or give them narcotics, and the ones that went home you did not? Or how did that differ?
So our postoperative strategy or the management strategy did not really differ between the two groups. Usually they're given Toradol in the operating room and then followed by alternate Tylenol and ibuprofen postoperatively. So usually opioids like oxycodone are rarely given, and they're reserved for those in need of additional pain control. And script for opioids is almost never given at discharge, but our data did show that those who stay longer postoperatively, they are more likely to be given opioids, which is sort of expected since those are usually the patients that are in need of additional pain control, and they also tend to stay in the hospital longer as well.
Okay, and lastly, since we have a little time, how do you plan on targeting those different socioeconomic groups that you mentioned in your poster to improve same-day discharge?
So I think the best way for us to improve would be to sort of assess these socioeconomic barriers to same-day discharge as early as we can, so we can make sure that we address them as early as we can. So for example, when it comes to going home after surgery, making sure that patients have, rides home set up in the case that their surgery goes well and they're able to go home on the same day and they don't have to stay in a hospital longer because they're not able to get a ride home.
Excellent. Thank you very much for your work, and thank you, Mr. Buss.
Thank you.
Our next abstract will be presented by Dr. Anjana Sinha from the Penn State College of Medicine. Her presentation is entitled Analysis of Cost and Outcomes of Intercostal Nerve Cryoablation versus Thoracic Epidural for Postoperative Analgesia Following the Nuss Procedure for Pectus excavata.
Hello, APSA. My name is Anjana Sinha, and I'm a third-year medical student at Penn State, presenting on behalf of my team on the cost and outcomes of intercostal nerve cryoablation versus epidural post-Nuss procedure at our institution. Of course, all of this work would not be possible without the rest of the team, who I would like to acknowledge: Noah, Dr. Kronfleet, and Dr. Sai. As you all are aware, the gold standard repair for severe cases of pectus excavatum is the Nuss procedure. Post-op, pain control is the predominant factor that must be managed, and cryoablation of the intercostal nerves has been suggested as a mechanism to decrease both the length of hospital stay and the total use of narcotics. So in our study, we were looking to examine both the costs and outcomes of nerve cryoablation in comparison to a cohort of patients who received epidural anesthesia. Our study included a retrospective chart review for all patients who underwent the Nuss procedure, procedure for pectus excavatum over an 18-year period between 2002 and 2020. Here we collected demographic data, type and duration of anesthesia, length of surgery, post-op length of stay, and post-op complications. We found that overall cryoablation increased the length of the procedure by approximately an hour, and that the length of hospital stay was decreased by approximately 2.4 days with the use of cryoablation. Additionally, the percentage of individuals using PCA and the number of days that they were on PCA was reduced, and a significant reduction was seen in the number of patients discharged on narcotics. Lastly, there was an overall lower percentage of in-hospital complications and readmission. But overall, the use of cryoablation is significantly more expensive for the patient, costing on average $36,000 more to the patient. In conclusion, intercostal nerve cryoablation during the NUS procedure resulted in a greater total cost of hospitalization to the institution and patient, and the additional associated costs with cryoablation and increased operating room time was not offset by the reduction of the length of hospital stay or in-hospital complication rate. And the total narcotic use was lower for patients who underwent cryoablation versus thoracic epidural anesthesia. Here's my contact information if you have any additional questions.
Thank you, Ms. Sinha. The invited discussant for your paper is Dr. Sean Kunisaki from Johns Hopkins Children's Center.
Thank you, Ms. Sinha. Fantastic talk on cryoablation and its comparison with epidural. I think this is really still an unanswered aspect of the care of these patients, and I think your group did a fantastic job analyzing a lot of the issues. I did have a couple of questions I was hoping you can help me with. First is, did you look at pain scores in your study? I know that there was lower PCA use as well as narcotic requirements, but did they correlate with any pain scores directly with regards to the patient during their hospitalization? My second question was with regards to the in-hospital complication rates associated with epidural use. Can you elaborate specifically on what those complications were? And finally, I was wondering if you had any idea how long it takes to place an epidural catheter at your institution. So obviously the anesthesiologist does that, and so that adds extra operating room time to the procedure. And so it would be interesting to find out how that time compares with the time it takes to cryoablate these nerves. Again, thank you, Ms. Sinha. Very much enjoy your presentation.
It's a pleasure to present and also speak to Dr. Kunisaki today. His first question was, what is the mean cost of cryoablation per patient? So we found our mean cost to be around $84,500, which is almost double the average charge to the patient receiving a thoracic epidural. He asked if we have any idea how long it takes for anesthesia to place the epidural. So our epidurals were traditionally placed in pre-op before going into the OR. So there is some source of difference in charge and costs, i.e. both would be higher, but the difference between the two is not totally certain. And also we've started doing some ESP blocks on cryoablation, which adds to OR time as well as charges and costs. His third question was if we had any explanation as to why operative time was greater than 1 hour with cryoablation use. He was wondering if there was any learning curve or any rationale for prolonged operative time. We agree that there was definitely a learning curve and that the cryoablation takes 2 minutes per space and 10 spaces were done on minimum, which adds at least a half an hour. And some patients were getting more spaces treated. There is some learning curve to both operating time as well as narcotic administration, which has also decreased from the beginning. His fourth question was asking if we looked at pain score between the two techniques. And he asked, even though cryo is more costly, it may be more effective in terms of pain control. So we were looking for metrics we could consistently find and collect of pain scores. And many of them have not actually been documented. But this is why we use surrogate markers of PCA use and time on PCA, as well as if the patient was discharged on a more rigorous pain control schedule. And additionally, we found that the literature does support that pain scores may be more inconsistent in describing pain. And his last question was, what were the in-hospital complications associated with the epidural use. So of the 127 patients with epidural, 65 experienced in-hospital complications. The reported complications centered around constipation, pain control, with one report of narcotic-induced hallucinations. Thank you for taking the time to watch this presentation and speaking to us today.
Thank you, Ms. Sinha. Appreciate your talk. Job well done.
Thank you, Ms. Sinha and Dr. Kunisaki. Our next abstract in this session will be presented by Dr. Simmons of the University of South Alabama. Her presentation is entitled Laparoscopic Inguinal Hernia Repair, Feasible and Safe in Very Low Birth Weight Babies.
Thank you for the opportunity to present our work. Laparoscopic inguinal hernia repair in the pediatric patient population is an accepted technique. However, there is a paucity of data about the safety and efficacy in our smallest patients, and the laparoscopic approach is often reserved for full-term babies. This study evaluated the safety and feasibility of laparoscopic inguinal hernia repair in the very low birth weight babies when compared to the traditional open technique. Here, you can see the technique used at our institution with a zygomatic awl being used for a percutaneous high ligation of the hernia sac. In this single institution retrospective study performed from January 2018 to January 2020, 46 neonates met inclusion criteria and that they were less than 1,500 grams at birth, did not have another concurrent operation other than circumcision, and did not have any prior abdominal operations. 29 had open hernia repair and 17 had laparoscopic repair. These neonates were then compared further based on if they fell to the less than or greater than 2 kilogram groups as shown in the graphic. Charts were reviewed for demographic, operative, and outcomes data. Descriptive and comparative stats were then performed and reported as means plus minus the standard deviation or mode plus minus the interquartile range. Demographics, birth weight, gestational age at birth, and at operation were similar between the laparoscopic and open groups. Babies in the laparoscopic group weighed less at the time of operation with less weight gain since birth. When we compared outcomes between the open and laparoscopic approach, there was no difference in length of surgery, stay, and follow-up, as well as no difference in intraoperative or post-operative complications and post-op respiratory support requirements. However, the laparoscopic approach had a higher hospital cost. Additionally, subset analysis comparing babies less than or greater than 2 kilograms, the neonates were similar, except the babies in the greater than 2 kilogram group had less weight gain at the time of laparoscopic inguinal hernia repair. Finally, we found no difference in surgical outcomes when data was separated by weight. In conclusion, laparoscopic inguinal hernia repair in very low birth weight babies is safe with comparable outcomes to open repair, may have comparable outcomes to open repair even in neonates less than 2 kilograms at the time of operation, and it is less cost effective than open repair. Thank you so much.
Thank you, Dr. Simmons. I am your discussant for this presentation. I enjoyed your work greatly. I'm a huge advocate of laparoscopic inguinal hernia repairs in babies. And so I just have a couple questions for you. I noticed a higher percentage of laparoscopic repairs were done on less than 2 kilo babies when compared to open only. We only did 3. Is there a different weight threshold for the 2 techniques at your institution?
No, we don't have anything like that in place. It's basically kind of randomly chosen based on surgeons that are on call when the consult's made from the NICU. And then out of our 3 pediatric surgeons, they prefer laparoscopic over open in those cases.
Okay, but they're not waiting they're not keeping the baby in the NICU until they hit a certain weight or something like that?
No.
Great. How long were your patients followed for recurrences or other postoperative complications? And do you know the recurrence rate for laparoscopic versus open?
Yes. So our study period was limited from 2018 to 2020 because we didn't start performing laparoscopic repairs until 2018. So that kind of limits the follow-up that we have, but we plan to continue looking at them prospectively, especially since most of our NICU grads follow up with complex care pediatricians at our institution. So the mean length of follow-up for laparoscopic was 8.7 months. And the mean length of follow-up for open was 11.5 months with a p-value of 0.253. As far as the complications due to recurrence, we only had 1 with the laparoscopic group and we had 2 with the open group, and that was with a p-value of 1. I also took note of what those complications were, and for one of the open ones, it was because of bilateral undistended testes, and that required a bilateral orchiopexy after a bilateral inguinal hernia repair. And then a second complication that happened with open repair that required re-op was that there was never a distended right testicle, but that turned out to be a congenital anomaly. And as far as the laparoscopic one, he had a lot of adhesions, this baby, due to NEC, necrotizing enterocolitis. So it was kind of like a false positive, thinking that there was a recurrence of a left inguinal hernia, but that turned out to not be the case.
Great.
Yes.
Thank you very much, Dr. Simmons. Great paper.
Our next abstract in this session will be presented by Ann Sesclafer from the St. Louis University School of Medicine. Her presentation is entitled "A Decade of Firearm Injuries, Children Caught in the Crossfire."
Firearm injuries are the third leading cause of death in pediatric patients and represent a significant cause of preventable morbidity and mortality. To better define evolving trends and avenues for prevention, we conducted a 10-year retrospective chart review of firearm injuries managed at our ACS-verified, state-designated Level 1 Pediatric Trauma Center in St. Louis, Missouri. Data was analyzed using students' t-test and chi-squared, and a p-value of less than 0.05 was considered significant. 645 patients were included in this study. The age distribution of firearm injury victims is shown in the histogram in the left lower corner of this poster. 67% of all patients were between the ages of 14 and 17. Looking at the pie charts, you can see that the majority of victims are male, African American, and from single-parent households. The line graph shows the total number of firearm injuries, as well as a breakdown of these injuries into assaults, self-inflicted injuries, and unintentional or accidental injuries. The first 5 years of the study, 2010 to 2014, are represented by gray dots, and the last 5 years of the study, 2015 to 2019, are represented by red dots. Overall firearm injuries are increased significantly over the course of this study, as did assaults and self-inflicted injuries. Within assaults, drive-by and random shootings increased significantly, with targeted violence uptrending. This matters because not only are injuries on the rise, but so are fatalities. Overall mortality in this study was 4%, with fatal firearm injuries increasing significantly over the past 10 years. Drawing your attention to the right upper corner, you will see a heat map of violence by zip code. A small area comprised of only 5 zip codes accounted for 38% of firearm injuries. For the entire cohort, 11% of patients were identified as recidivists with either documented prior or subsequent firearm injury, and 41% of these recidivists came from these same areas. In conclusion, pediatric firearm injuries are increasing, and the geographic concentration of violence presents the opportunity to deliver targeted interventions to these populations to curb the spread of violence. Thank you.
Thank you, Dr. Sesclafer. Your invited discussant for this paper is Dr. Christian Walters from the Children's Hospital of Georgia.
Dr. Sesclafer, I enjoyed your presentation on the problem of firearm violence in children. It's disturbing to see that this increasing trend has been sustained over multiple years, and it's not just an isolated one-year variance. I only have one question. What, if any, are your planned targeted interventions in the areas of greatest geographic concentration to decrease the rates of violence in this vulnerable population? Again, great job, and I look forward to your response.
Thank you, Dr. Walters. You hit on the most critical question that our study raises, which is how do we stop this violence? The first thing to note is that not all of the firearm injuries were violent in nature. 14% were accidental, so that's low-hanging fruit. Kids should not have access to guns. This can be addressed through gun lock programs and through education of parents on safe gun storage. And physicians should ask at every well-child visit about gun ownership and safe storage and provide appropriate resources. The more difficult question to address is how to reduce violent assaults. Violence has many etiologies, and interventions will require a multifaceted approach. We've already implemented hospital-based violence intervention programs at our institution, but these services arrive too late after an injury has already occurred. We need to act sooner. That's why we identified these major hotspots where the majority of injuries are taking place in our communities. And we saw that these are highly correlated with known socioeconomic determinants of health, things like high poverty rates, low education, and unstable family systems. Therefore, we're advocating for more focused delivery of community resources to these specific zip codes. We're looking for things like improving the quality of schools and improving after-school supervision, increasing job opportunities, reducing drug crime and gang violence, and even possibly opening up a satellite trauma clinic to be able to provide additional support on the ground.
We also need to reduce access to guns. We know that rates of firearm injury are directly correlated with state legislation. This means advocating for stricter gun laws to ensure that guns are not getting in the wrong hands. And finally, we need people to care. This needs to be a community response. We need to communicate with our local law enforcement and media to ensure that the public is aware that this is a growing public health crisis and that while we've identified hotspots, no one is immune. Too often our children are getting caught in the crossfire of violence, and together we need to protect them. Thank you.
Thank you very much, Dr. Sutzpfeifer and Dr. Walters.
I am Dr. Sean Kunisaki from the Johns Hopkins Children's Center. Our next poster will be presented by newly graduated Camille Mesquia from the University of Florida. Her presentation is entitled Maintaining Outcomes in Congenital Diaphragmatic Hernia Using Protocolized Care.
Hi, my name is Camille Mesquia. I'm a fourth-year medical student at the University of Florida. Today I will be presenting Maintaining Outcomes in Congenital Diaphragmatic Hernias Using Protocolized Care. Special thanks to Dr. Islam and the UF Pediatric Surgery Department. Congenital diaphragmatic hernias are birth defects impacting roughly 1 in 3,500 births in the United States. CDH may lead to serious complications including lung hypoplasia, pulmonary hypertension, and infant mortality. In a prior study, our institution described the increasing survival rates at UF Shands over the past 20 years. This study examined the evolution of how we treat CDH and how this led to increases in institutional survival from 13% to 85% from late 1970s to early 2000s, with the transition from hyperventilation and alkalosis as seen in ERA 1 to the addition of ECMO in ERA 2 and improved ventilatory management in ERA 3. Between 1992 and 2011, there was a survival rate of 88% for infants without lethal anomalies and an overall survival rate of 79%. In this study, we further explore the evolution of management of CDH and how it is impacting survival rates. In 2015, our group shifted from a single surgeon to team-focused management. This study evaluates whether continuing the established management principles in a team model would preserve high survival outcomes. Care for CDH patients was protocolized with respect to ventilatory management, ECMO use, timing of repair, and technique of repair. This was an IRB-approved retrospective chart review of 37 CDH repairs between 2015 and 2020. The cases were split into a pre- and post group of 15 and 22 cases respectively. While there was a significant difference with higher presence of liver herniation in the pre-group, patient demographics and prenatal care for both groups were not significantly different with respect to important prognostic indicators, including CDH study predicted survival, presence of hernia sac, defect size, and ECMO use. CDH study predicted scores were 0.61 and 0.67 respectively. This data continues to demonstrate a high overall survival rates of 82% in the pre-group and 91% in the post-group, which persist with the shift towards team-based management. UF Shands continues to adhere to Dr. K's firm belief that every baby with CDH has the potential to survive. It is our hope that the study of CDH management can continue to improve infant survival. Thank you.
Thank you, Dr. Mesquia. Your invited discussant for your presentation is Dr. Sean Kunisaki from Johns Hopkins Children's Center.
Thank you, Dr. Mesquia. A fantastic presentation and really illustrative of the team approach. It certainly is compatible with some of the great outcomes that have been coming out of the University of Florida. I did have a few questions, however. First is that I noticed in your talk that the annual volumes actually declined with the team approach. Can you explain a little bit about why that is? For example, were there patients that were excluded from the study as a result of the transition? Were there changes in referral patterns or the severity of CDH managed at your hospital? Another question is that was not very clear from my understanding of the paper is did you look at defect type as well as the lung-head ratio in your study? Again, fantastic work. I very much appreciated your talk. Thank you.
Thank you, Dr. Kunisaki. In the post group, the patient volumes did decrease due to the referral basis. When Dr. K's left, the patients largely went with him to his new practice. We did not have any specific exclusion criteria that would have impacted the number of patients in the pre versus post groups. The change in management went from multi-surgeon to single surgeon to multi-surgeon, but there weren't any changes in the basic principles of management of care. We looked at all available pre and postnatal data impacting our survival rates. However, there were a lot of variations when it came to lung head ratios and MRI volumes, and even the size and types of defects in the recordings. I think in a prospective study that would be better retained and able to be analyzed across. So we mostly looked at accurate postnatal data and CDH survival group predicted values to compare the severity of cases.
Thank you, Dr. Meskia. Again, appreciated your talk and congratulations on your recent graduation.
Thanks, take care.
Thank you, Dr. Meskia and Dr. Kunisaki.
Our next poster presentation will be presented by Dr. John Rubio from the University of Massachusetts Medical School. His presentation is entitled A Multidisciplinary Approach to Alcohol and Drug Use Screening and Prevention for Adolescents and Inpatients.
Hi, I'm John Rubel, and I'd like to thank APSA for allowing me to present our work today. SBIRT, or Screening, Brief Intervention, and Referral to Treatment, is an evidence-based practice used to identify, reduce, and prevent alcohol and illicit substance use and dependence. In 2006, the American College of Surgeons mandated that all Level 1 and Level 2 trauma centers screen patients for alcohol or other drug use using an SBIRT framework. Both trauma-related and non-trauma adolescent inpatients present a window of opportunity for screening and intervention with the goal of reducing future substance-related disability. Our project sought to study how effectively SBIRT was being conducted for our adolescent patients, if screening rates improved when multidisciplinary staff training was paired with an EMR tool, and finally, if disparities existed throughout the SBIRT process. We first created an EMR tool for hospital staff to use when screening patients. Next, they were educated and trained in SBIRT screening, and finally, pre and post implementation periods were compared. All adolescent patients between the ages of 12 and 18 years old who were admitted to the pediatric ICU or ward were included. Patients with a primary admitting psychiatric diagnosis were excluded from the study for ease of data analysis. Our study included nearly 2,000 pediatric patients and found that staff training paired with the SBIRT EMR tool increased screening compliance by over 34% and over 79% in recent quarters. These graphs show that post-implementation patients who screened positive had different rates of brief intervention in the form of social work consultation when comparing patient sex and race. Patients that were female and or white received a social work consult more often. We also found that patients who primarily spoke English also received both social work consults and psychiatry and psychology consults more frequently. In conclusion, the study found that SBIRT screening improved when hospital staff training was paired with an EMR tool. However, demographic disparities may exist among those who receive additional brief interventions and referrals. Future studies may seek to improve social work engagement with non-English speakers. Thank you for watching our presentation.
Thank you, Dr. Rubio. Your invited discussant for this paper is Dr. Anthony Stallion from Beaumont Children's Hospital.
Well, Dr. Rubio, thank you very much for a great presentation and something that is of an immense importance to us in caring for the younger patients, and from the standpoint of how stressful it has been over the last 18 months. So we've seen the alcohol and drug use go up significantly. I have two questions for you. What downstream outcomes did you impact in the post-implementation phase versus the pre-implementation? And the second question, what have you done with the data or action plans developed given the inherent health disparities that you have uncovered?
Thank you so much, Dr. Stallion. Implementation of this project gave our nursing staff more ownership over the screening and social work consults, allowing the team to unify together for the benefit of our patients. This was particularly true during the post-implementation period when there was greater awareness around this problem. We then worked on developing a culture of screening all pediatric patients for drug and alcohol use, not just patients on the trauma service. This led to collaboration between physicians and nurses, but also generated the data and impetus to apply and advocate for additional social work funding to address this issue. With regard to your second question, during the pandemic, interpreter services may not have been as available in person versus virtually. However, over the past 6 to 12 months, we've rolled out portable and easily accessible video interpreter iPads that are quick and easy to use. This has improved the use of interpreter services and expanded our ability to appropriately communicate with all families in their preferred language. Additionally, much of the literature on reducing healthcare disparities is aimed at standardizing product protocols. We'd like to pursue this along with educational campaigns in hopes of minimizing the discrepancies we've uncovered.
Thank you, Dr. Rubio and Dr. Stallion. This concludes our session. Thank you all very much for watching. Hello, everyone. Welcome this evening to our medical student and resident social reception, which is virtual. Thank you for joining. I hope you all enjoyed the medical student poster session right before this. I have a great panel for you today. We're going to record a few questions that you're going to hear live, and then you're going to have a half hour of question and answer time to ask all of your burning questions about your interest in becoming a pediatric surgeon. So I'd like to just briefly introduce our panelists, and then we're going to start right in with some questions. So first we have Dr. Grace Mack from University of Chicago. We have David Notrika from Phoenix Children's. We have Pramod Pulaganda from McGill to represent our Canadian cohort. We have Erin Garrison from Cincinnati Children's. And this year we are happy to also have a fellow on our panel, which is Faida Badru. She's the fellow at University of Florida. Our moderators are myself. I'm Jill Whitehouse. I'm a pediatric surgeon at the Joe DiMaggio Children's Hospital in Hollywood, Florida. And I also have Louis Lee from Texas Children's. And we have our resident member on the education committee, Sydney Imel, who is at Toledo right now, finishing up her general surgery residency. So with no further ado, to not waste any more time, our first question that we're going to ask on behalf of all of you, because we know what's on your mind, is what would you recommend to a medical student, either in their early medical school years or third or fourth year, who is interested in pediatric surgery? And Dr. Mack, I'm going to start with you. What would you like to offer to medical students?
I think probably the most important thing is really to try to get as much exposure to pediatric surgery as you can. So whether that's taking an extra rotation, or if it's possible over the summer to do a shadowing opportunity, anything that you can to really see what pediatric surgery is really about. And then I would also recommend doing, obviously on your surgery rotations, making sure that you really enjoy all of general surgery as well, because obviously there's a lot of overlap between the two.
Great, thank you. Dr. Notrika, do you have any follow-up advice to a medical student?
I think it's super important for medical students to be careful where they choose their general surgery training program. And you want to make sure that you go to a program that will get you good exposure to pediatric surgery. If you have the opportunity to train in a program that has a fellowship training program, I think that has a few advantages. I wish it didn't, but I think it does. Having exposure to multiple pediatric surgeons during your general surgery training will help you make sure that you are picking the right career for yourself. It will also give you other opportunities to impress multiple faculty members. And I think when it comes time to do your application 3 or 4 years down the road, that's incredibly helpful.
So, sorry, Dr. Garrison. What would you recommend for residents who would like to match into pediatric surgery?
I think really just having an open mind as far as what kind of programs you might like as a fellow. Dr. Badru can tell you that when you're going through the match, you're probably really trying to figure out where you fit from a personality standpoint, but also from a workload standpoint, or from a exposure to different types of pediatric surgery and what types of cases and things you're going to be seeing. I think all of the fellowships are busy. They're all going to train you very well. And you kind of have to find what feels right to you as far as, day to day, and then with your long-term career in mind.
And so, Dr. Pulaganda, what do you think? What did you recommend for residents
Yeah,
who want to match surgery?
Yeah, so as Dr. Garrison said, I think it's really important that there's this element of commitment, there's this element of being involved. I think that you talk about some of the aspects of what you're looking for in a program. So obviously everyone looks at volume, everyone wants to look at the type of exposure that they're going to have, but I think it's also really important to look at the people that are there. I think that you should be looking at potential mentors, because these are the people that are going to be guiding you for years to come. And I still talk to my program director 20 years out when I'm in a tough bind and ask them for help. So I think there's that element of mentorship, and I think that's really, really important. That certainly guided my decision of where I wanted to go.
Can I add something, Louis, that I was just thinking about? I think my answer was a little geared towards the later residents, but it's just as important for kind of the PGY1s and 2s. Some of the best advice I got was really just any rotation that you're on, you have to, try your best. Don't just hold it all back for peds surgery. You want to be one of the go-to residents that everyone's excited to have on their service at that time. So don't put all of your eggs in the peds surgery basket. Get well trained in everything, because as one of the great things about our field is that we get to do a lot of different things.
Dr. Badru, do residents need research? And if so, how many years and what type of research will make residents more competitive?
Thanks, Sydney. I do think that residents need research. The question of how many years, it's very individualized, I think. It's really just about making sure that you understand the process that goes into research. You're an academician as well, and you're able to make evidence-based decisions based on either what you contribute to the literature or what's out there. In terms of how much you need, that's, I can't tell you exactly. There's no number, there's no magic number. Every year we hear about people with a lot of research that didn't match, and then we hear about people that don't have a ton that did match. So it's a whole person. It's not just the research. The research is important because, like I mentioned, there's certain things that you gain from spending some time in academics and the process and all of that goes into it. But what also matters is your work ethic, how you love what you do. That comes across. People see that. If you truly love what you do, even if you don't have 50,000 research, you always have people that go to bat for you, which I think is just as important as the research component. So yes, spend some time on research, but also spend time honing your skills. Just enjoy what you're doing, and that comes across.
Ooh, I'm going to play devil's advocate. And so Dr. Mack, I'm going to say I'm a resident. I heard that I have to do 2 years of basic science research and I have to have at least 10 publications to even stand a chance. Is that true?
No, that's not true. That being said, I will qualify my answer. I think the most important thing is that you have a resume or a CV that is competitive, right? And so I think classically that has included 2 years of basic science research. Nowadays, I don't think that always is true. Oftentimes it can be clinical research, it could be an MBA, it could be really anything where it is time spent outside of residency. And part of that, to Dr. Badru's point, I think is to show that you're a well-rounded individual. So it's not just about the residency, it's also about what you can do outside of that. It doesn't have to be 2 years, it can be 1 year, but the most important thing is you have to show that you're productive. And I think that speaks to your work ethic and your academic potential, et cetera. And so, really what I tell residents is that anything that they want to do, anything that interests them, that's what they should do, but they do have to have some dedicated time outside of residency where they can do that. And they have to show that they're productive. And that doesn't just mean an MBA degree, that also means projects, publications, and that sort of thing. Because unfortunately, even for us as getting promotions, the only way to show that you're productive is with publications.
Is anyone else frothing at the mouth and want to weigh in on this topic? Because this one's a hot topic. Dr.
Yeah, as someone who did not do very much research before pediatric surgery and does a fair amount of research now, I think that you need to have enough publications to prove that you have the capability to do it once you get done. I think Fadu's comment that there's no magic number is absolutely right. I think, you know, if you have 0, that's the kind of the opposite of a magic number. There are some people who can start projects and can't finish them, and they're going to struggle throughout their entire academic career. And I think that it's important to be able to show that you can finish a project, you can take the project to completion. Super important there. Basic science versus clinical research versus versus other type of research. I just think that you need to prove that you can write and that you can be analytic.
Great. Dr. Pulaganda, anything different on the other side of the border?
No, I think it's pretty much the same. I think certainly in Canada, perhaps the opportunities for research are a little bit more reduced. Most people end up doing advanced degrees, which is a lot of coursework. It's dedication and commitment, but perhaps not the product output that you would like in 20 publications, for instance. But I think what it does demonstrate, again, one is, you know, as Dr. Nochka said, commitment, the ability to finish a project, to ask the right question, which is, I think, something that is really cool, and something that you'll develop and hone as you go through. But it's also really important to understand that most pediatric surgeons who have done research do not continue to do that same kind of research when they finished. And I actually am a very firm believer that the later you do research in your career, the more likely you're going to find the niche that stimulates you and pushes you forward, and the one that you're going to be most productive in. But again, that's just a slight segue of, or offshoot of this discussion. But I do think that commitment to something outside of the residency program, as Dr. Mack said, is really, really, really important, and to demonstrate your commitment.
Excellent, thank you. Louis, you want to take the next question?
Sure. Dr. Mack, how many letter writers would you recommend that would be pediatric surgeons versus to write your letters for fellowship?
Honestly, I don't think there's truly a magic number. I think the most important thing is that the people who write your letters know you and know you well, and they can write you an honest letter. Because what you really don't want is a letter from, like, let's say the chief of pediatric surgery who really never interacted with you, and then everything is very bland and you don't get a lot of detail, because that letter is just going to be, sort of disregarded either way. So I would really recommend that even if you don't have any pediatric surgeons, that all of them know you well and can write well for you. And sometimes I think that means that as a resident, when you're going to someone to ask for a letter of recommendation, you also have to honestly ask them, do you feel like you can write me a letter, like a good letter? Because sometimes the answer to that question is not yes. And it's better to not find that out then, as opposed to later on when your letter goes through the application process. Obviously, I think if you have a pediatric surgeon that does know you well, then you should ask them. But the most important thing is that they know you well.
Dr. Garrison, what are your thoughts about that question?
I don't think I have much to add to that. That was a great answer, and I don't know, it was like a debate question to the way she answered that.
Can I be the con to that?
Oh yeah.
Sure, absolutely.
So I actually do think that it is slightly important to know who you're asking your letter from. And I thought the recipe was you get something from your chair, you get something from your, at least one pediatric surgeon. And, really, when you look at it, we're still at what, 1,200 pediatric surgeons, maybe 1,300 across North America. It's still a pretty small club. And I must say, as we do with anything in life, if I get a letter from, Dr. Nochka or Dr. Lee or Dr. Mack, I know these people, I can trust them, and your kind of personal, if you're putting someone out there, I mean, you don't want to put someone out there that you don't truly believe in or trust in. So I think it's really important that when you get the letter, and if I know that individual and I trust their judgment and I trust their opinion, then that really goes a long way to someone who I may not know, who may be the stellar resident in their program. And that I find that as a program director really hard to balance, because I have someone who's a star and a letter from someone that I don't know. And then I get a letter from someone who says that they're a star and I really know them and I really value their judgment. So for me, I find that's always a struggle for me. I'm not saying that I have a magic answer for that, but I do believe that you should be very careful, as Dr. Mack said, about who you want to write your letter.
Can I jump in here for a second?
Yes.
So I agree with both Dr. Mack and Dr. P, what you've said about both things. I think that this is where it comes into a little bit of, if you're early on in your training, whether you're a medical student or you're resident, strategically positioning yourself in a way that you spend a lot of time with pediatric surgeons that are trusted in the field. I'm not saying all your writers should be pediatric surgeons, obviously, but being able to strategically do rotations and electives and things like that, that allow those pediatric surgeons to know you, so that then they can write you letters that at some point, hopefully, Dr. Fumiganda can see those letters and trust who he's getting it from. And it's kind of the best of both worlds, in which case the people writing the letters, they know who you are, and they're writing it from a position of truth and a position where people can trust it. So if you have time, you can invest some of that in some strategic positioning.
I think Dr. Badru just nailed it, which is you need to start early, and that means that you need to identify the people who are the program directors, unfortunately, or the people who are experienced in pediatric surgery, and start working with them. And so that when it comes time to have a letter, the question is not, do you know me well enough? It is how strongly are you gonna support me? And you know, that doesn't happen by you just showing up when it comes time to apply. It comes from identifying what you want to do and working on it for 2 years in advance, so that there's no question that by the time that they write that letter, they know exactly who you are and how you're going to perform when you get to your fellowship training program.
Thank you so much. I think we have time for one last short question. And Dr. Badru, we're going to put you on the spot here because you are a product of a one fellow program. Can you offer any advice about when you're actually zoning in to pick fellowships? Do you think there's any advantages or disadvantages over a one fellow program versus a two fellow program?
Oh, certainly. There's certainly advantages and disadvantages to both. And I think that most people, even not being in a single fellow program, can probably accurately describe what these are. From an advantage standpoint, because obviously we always have to start with the good things, it's just you. So in that way, you have the opportunities to do all the index cases, right? Every single one. I'm only towards the end of my first year, and I've done a lot of really fun cases. But that said, it also means you're alone. So you have to do all the administrative stuff that goes with fellowship as well by yourself. And maybe the transition from residency to fellowship is not as easy because you don't have someone to show you the ropes. But there's advantages and disadvantages. Part of the advantage is also you're the face of the program, right? When you start out, you're not in anybody's shadow. So, everybody doesn't call your senior fellow to talk to them about everything, and then it kind of trickles down to you. They call you because you're the natural next step. So I like it. I really enjoy it because being the single fellow gives me control of my life in a way that I don't know that I would have otherwise, which it's not negative, but it just means that from a planning standpoint, from a being able to completely immerse myself in the experience without having anybody to kind of share that with, it's definitely a positive, especially because I can use my attendings, especially my more junior attendings, as some of that spot for camaraderie. Now, there are days where I wish I had a second fellow. I really wish I had a senior fellow. I've heard about senior fellows and junior fellows and the camaraderie and the way they take each other through cases and the things that you can talk to each other about. And when you become a senior fellow, being able to act as an attendant to a junior fellow, but not like, I could do cases with residents right now, but it's not the same level. So having that level when you are and truly getting into that position where you can truly be a pretending type thing, I can only imagine that is amazing. I'm never going to experience it, and that's okay. But certainly there's some advantages and disadvantage. I think ultimately, I wouldn't have it any other ways. I know what I'm missing, but I love what I'm getting, and I'm okay with it. So,
well, thank you. Thank you for that insight. And as promised, I knew this was going to be short, but thank you all for your answers and your insight. And we look forward to the next 30 minutes, which will be live, and we will take all of your questions and answers and read them as they come in. Plus, we have several more questions we can ask our amazing panelists. So thank you to all, and we will see you soon. Good evening, everyone, and thank you so much for joining us for the live portion of the session you just watched. We have all the same panelists, and I have a co-moderator this evening. We have Dr. Ileana Ghaffar, who joins us from New York City, and our 5 amazing panelists, who I won't reintroduce. We're all here and excited to take your questions. So please ask questions in the chat. We will address them. We have some more questions we're going to ask our panelists and challenge them a little bit while you all are thinking about more questions to ask them. So let's start right in. This was a question that we all kind of talked about. This is a challenging one. How difficult is it to match into pediatric surgery if you are an applicant from a non-traditional pathway? I'm going to give you a couple examples here. One, let's say you're a late decider who your CV is filled with cardiothoracic research or plastic surgery research and something, and then you decided pediatric surgery in your 4th or 5th year. Another example, if I'm a foreign medical graduate, how challenging is it to match? And how about the one that comes from a community program? Maybe I wasn't able to do research. Maybe I took a different path to become a pediatric surgeon. So how do those factor in, and any advice that you have for an applicant in that position? I'm going to start that question off with our fellow panelist, Dr. Bedru.
Thank you, Dr. Whitehouse. This question is quite near and dear to my heart because some of those things apply to me. I'm an IMG. I attended an international school. I also started my residency at a community program. And although I did not finish the program, there were a lot of things that I learned that helped me along my path. The first was I wasn't really a late decider. I knew quite early that I wanted to do pediatric surgery in my PGY 1 year. And I think some of the things that helped was one, really focusing on my strengths rather than those things that may be considered as more challenges or not being straightforward mainstream. So making sure that in the other aspects, I'm pretty strong in terms of research and community outreach, and just making sure that I emphasize the things that I bring to the table that might not be traditional. It's very interesting when people look at your CV because they're like, oh, this is interesting. I haven't seen this before. So I think that being able to focus on that is very important. Like I stated before, I started at a program that was a community program and people didn't go out for research routinely. And I actually just went and talked to my program director early so that they could work on getting someone into that spot that that the PGY 3 or the PGY 4 would have gone into to allow me time for research. So sort of, moving things around and allowing myself an opportunity to be able to, set myself up, maybe not become a traditional applicant, but put myself on at least a good level so that although I have unique experiences, I also have things that allow me to appear competitive because, everyone is unique.
Great. Dr. Mack, your program director, tell us when's the last time, a very unique applicant came across, and does that factor into whether you grant an interview or not?
Yeah, I think that this is something that all of us as program directors have been looking at in ways to really try to make sure that we include everybody and try to diversify our own group. I think for us, when we're looking at applicants, the biggest thing for us is really that you're well-trained. So whether you come from a community program or university program, we want to make sure that you're a well-trained general surgeon, because that's really the starting point for becoming a good pediatric surgeon and us being able to train you. And I completely agree with Dr. Badru that one of the things that just because you don't have a year or 2 years to do research, if you try to do research during your residency, that shows that you have that same drive and motivation and the ability to complete projects, which is really what we're looking for when we're talking about research. And I think making yourself a unique candidate that really stands out is, something that we all look for when we go through applications. There's a lot of applications that we have to go through. And so you really want to be able to stand out. And you want to make sure you sort of check the majority of boxes, right? So that your APSAsode scores are okay, that you have some research, even if it's not time, at least publications. And like I said, that you have a good training.
Great, thank you. Ileana, you want to take the next one?
Yeah, the next question is, there's a number of other sorts of fellowships that one could do, like critical care, ECMO, oncology, MIS, or colorectal. Do you recommend doing them? If they are going to do them, when, and what are the benefits or other things you might have to say about those opportunities that are out there for people to consider? I'll ask Dr. Garrison first.
Thanks. That's a great question. I think subspecialty fellowships are great for maybe two different types of candidates. Someone who may come from a community program that hasn't had a lot of exposure to pediatric surgery, or who hasn't maybe gotten, hasn't convinced themselves or others that they really want to do pediatric surgery, and just kind of being in a very busy kind of pediatric environment. The other one would be maybe an unmatched person who, for whatever reason, didn't match and is trying to strengthen their application. We've got a decent number of subspecialty fellowships at Cincinnati Children's, and each person is different for their reasons for doing them. This year we had a couple people just kind of filling a gap year, which was really nice. But I think ideally they're for people who are just kind of trying to maybe prove or get to know some more people in pediatric surgery and get an opportunity that way.
Dr. Notrika, do you have anything to add?
Yeah, I've actually taken a bunch of Aaron's people. All of our fellows except for one has actually done an additional fellowship, and this kind of goes back into my current belief, where I don't think 2 years is quite long enough to train a pediatric surgeon, and so I do think that having the additional training, especially if it's in colorectal or fetal or trauma or critical care, really does help, because it's that much less you have to learn during the 2 years. And I do think that it makes a difference. It's not that you can't learn the surgery in 2 years, but if you've had that third year, by the time you get there, you're really well positioned. So yeah, I definitely tend to favor clinical fellowships.
I also think there are a lot of advantages for when you do finish fellowship. I think I have 3 or 4 partners who maybe didn't match the first time and then did subspecialty fellowships, and it really sets them up for their career after that. So it's really, it can be a good opportunity and help your career in other ways that you may not appreciate at the time.
Great. I want to acknowledge the chat box because there are lots of questions coming through. So there's a few that tie into some questions we're going to ask later. So thank you for bringing those in. But one right up at the top, which I think is rather relevant, we should address. Someone asks, what do you think the upcoming interview season is going to look like in terms of virtual versus in-person, and how that has impacted the interview trail? Dr. Pulaganda, we haven't picked on you yet.
Sure. I would have to say, at least from the scuttlebutt that I've heard, that the interview season this year virtually actually went really, really well. I think there were lots of pluses. I think it was easy to schedule. I think the lack of travel, the lack of expense really favored the applicants. I know certainly you'd love to be able to have that personal interaction and often be able to see how a fellow would interact with their peer group. When we do interviews, we invite 4 or 5 fellows. So it's always nice to see how that interaction works, because someone can be on best behavior for 30 minutes in front of a TV screen. But I do believe that, if you look at it and that from a cost perspective, and this has actually been it's not just the financial cost, but it's the pre-call and the post-call. There's a tremendous amount of impact. I think there's also been pushback from program directors in general surgery where residents disappear for 2 months because they're doing interviews. So I think you're putting it all together. I think, I think a lot of the information that we need comes from your application. I think the interview does help. I know some centers have actually tried to do a pre-screening so that they do a pre-screening for everybody, and then they will narrow it down to the 10 or 15 people that they really wish to interview. So I do believe that the virtual format is probably going to be here for a while.
Sounds good. The next question is, what meetings do you recommend attending both to share research and for networking with faculty? We'll go back to Dr. Mack.
Yeah, so honestly, I think APSA, so obviously the one that you're currently watching, because that's where you're going to probably have the biggest bang for your buck in terms of meeting different pediatric surgeons all across the country. And definitely, if you're there presenting your research, then I would definitely talk to the person who you did research with, because oftentimes they will really be your greatest advocates in terms of taking you around and introducing you, and really making sure that you can network and then present your research.
Dr. Garrison.
I actually think just getting out there and getting experience presenting is probably more important than feeling like you have to go there and network. I know we hear that a lot of times on the interview trail or in with some of the students and residents, but it's most important to just get things on your CV and get the experience doing things that you're passionate about than kind of going and trying to meet people. At least that's my opinion. But I remember worrying about those same things back then too.
So thank you, Stephen, for asking this next question in the chat. This comes up every single year, and I think it's a great question. So this is a third-year medical student who's asking this. So elaborate on the advantages of training in a general surgery. So picking a general surgery residency based on whether or not they have a good pediatric surgery fellowship or not, or a good children's hospital, maybe they don't have a fellowship. Basically, how important is it to do general surgery where there is a pediatric surgery fellowship? So this ties into this whole non-traditional thing because not everyone can do that. Let's see, Dr. Notrika, what do you think about that?
I think that the inherent advantage of going to a place that has a pediatric surgery fellowship is that you've got a shot at that program. But more important than that is that the people who are writing your letters know what it takes to be successful in pediatric surgery. So I do think that there's an advantage to going to one of those programs. Does that mean that that you can't get a spot if you didn't? No, absolutely. Matter of fact, if you look at the people who matched, a lot of them went to places where there was no fellow. And so they actually got a better pediatric surgery experience. So I don't think that it's one way or the other. If you're playing the odds, going to a place that has a training program definitely favors you a little bit.
Great. Anyone else have thoughts about that on our panel?
I did train, so I wanted to go to a place that had a fellowship, and I ended up not matching at a place that had a fellowship, and it ended up being the best thing. I got to do ped surgery as a first year, second year, and fourth year, and got to kind of learn how to be a fellow and see patients in the NICU, where I know residents who rotate at places with fellowships don't kind of have that kind of first exposure to the patient. So I think you need to find a place that you feel like fits and that can get you your career goals. And I don't think it necessarily matters whether it's a fellowship or not. But I think if you really know you want to do pediatric surgery, then going to a place with a fellowship may be the best choice. But don't feel like it's an all or nothing. I think going somewhere where you get good experience and where you get a good exposure may actually set you up to start fellowship a little bit with a little bit more experience than going to a fellowship program.
And just to kind of speak to that, I kind of agree, kind of similar to what Dr. Mack said earlier. Getting good general surgery training is probably the basis of selection of the general surgery program. It is good, obviously, to look to the future. And so when I did start out at that community program that I mentioned, there was someone that had matched into pediatric surgery within the last 5 years from that program. But then I went out for research and I switched to a program that has a fellowship, and they hadn't matched a pediatric surgeon in about a decade. That's not a negative per se, because from a strategic standpoint, you're placing yourself in a place that has a fellowship. It's a great training program and everything, but there's pros and cons to each thing. So I had that alumni from my from my community program being able to, but then I also had the pediatric surgeons from my new program to be able to, to look up to and stuff like that. The whole point of that is just saying that you got to look at the program itself. You got to look at where you're going to get great training, and then where you're going to have good mentors to help you achieve the goal that you want to achieve, whether or not that be being in a place that has a fellowship or being in a place that don't. As long as you have good mentors that will help you along the way, I don't know that it matters ultimately that label itself.
All right, another question that came up, which is another anxiety-provoking thought that a lot of people have, is what are the common themes among those who don't match, the unmatched applicants? And are there any common weaknesses that you've noticed kind of come up in the people who unfortunately don't get to become pediatric surgeons? I'll leave that one up for anyone who wants to say.
Maybe I can start with that. So, look, what we deal with on a regular basis, or what I deal with on a regular basis, is I have 65 to 75 stellar applicants. And based on paper, I have to try to figure out who's the best one. And I could throw all the papers up in the air and let one fall and then make my decision, and I would be very, very, very happy. I think, there are many themes I think that do come through. One is there engagement? Is there commitment? Are you really, again, I think in this, what maybe Dr. Mack had mentioned in the recorded session was, are you the go-to person in your program? Are you the resident that really stands out in your program in terms of work ethic and getting things done? I think that really shines through. So you don't want to take, sort of just focus all of your efforts in pediatric surgery. I think one of the other things is finishing, the ability to take on a project and finish the project. And, often the surrogate for that is publications. So you need to have a certain number of publications. So, I look at abstracts, and then I look at, okay, well, how many of those abstracts actually translated into a paper? Because for me, that is kind of a little equation that I do in my head, saying, okay, we can get things started, but let's see how well we finish. And I think the other thing is also the letters. I think sometimes you may have one really good letter, but then you have three kind of meh letters because they don't know you well enough, or they don't have the details that would set you apart. And perhaps the last comment I'll make is that I think I've heard, we've all read personal statements. If I had a nickel for every time I heard about the breadth and diversity of the specialty in a personal letter, I wouldn't have to do pediatric surgery anymore. So the issue comes down to, how can you make it personal? How can you make that connection with me about your experience? And this perhaps also delves into the whole DEI aspect, and about distance traveled, and about what you've been able to accomplish and what you've done, because everyone has a very different journey along the way. So I'd love to hear that, because I think that for me is a connection that I might be actually able to foster as well. And I'll just make one last comment about APSAsode scores. Bad APSAsode scores, I study for your APSAsode. That's my message.
Thank you. We all hate to hear that word, but we understand what you're saying. Okay, so this appeared in the chat very early on, and it also was one of the questions we were going to ask the panelists, so this is great. Claire asked us, how much do personal phone calls impact fellowship interviews and offers? And along those same lines, post-interview follow-up. So how do I convey interest in a program Do I get my chairman to call? Do I send an email? Do I actually pen and paper? Thank you. What is the best way to go about doing that? Dr. Mack, you're back up.
I think that is something that we've actually all sort of also been looking at as a group of program directors in terms of, again, does that sort of pigeonhole people so that only if you know a pediatric surgeon, only if you go to a program that has a pediatric surgery fellowship, will you be able to get these phone calls and that sort of thing. And so that is actually something in terms of bias and diversity that we're really actually trying to work on as a group to not allow that to have as big of an impact as it probably did in the past. I think sort of like what a lot of people have already said today, it's very important to have people who write your letters and who can advocate for you, who know you well. And obviously it's great if they are a pediatric surgeon, but if they're not, they can still advocate for you and write a good letter. They can always make phone calls and that sort of thing. But I know for our group personally, we don't use that to help either one, decide to give the interview, or two, change anything on the rank list afterwards. And we've also tried not to do any of the reaching out on our end to people for the exact same reasons, to try to eliminate some of that bias. And in terms of the post follow-up, in terms of writing the letter, the email, and that kind of thing, I think it's nice, but it definitely doesn't change anything either. And it is definitely a lot of effort for people to do it. So I don't have strong feelings either way. I definitely don't think that it hurts you or helps you.
Dr. Badru, what did you do after you interviewed? Did you send letters? Did you email? I'm old school. I totally wrote letters. I'm embarrassed to say it.
I'm sorry, new generation.
I know, I'm old. It's okay.
So the fact is also that, I think I could imagine, the people that are the interviewers, they have all these people, like they have all these letters, and they have all these, everybody's sending them these letters and cards and emails, and I feel like it's a lot. So usually what I did when I interviewed was, by the time I got to the airport, I wrote all the letters, all the thank you letters for your time or whatever. And then I always try to include something personal from our conversation. And just, to just show that I remembered our conversation, and hopefully you remembered our conversation. And I do that for job search, everything. I've always done that. And I think that's really powerful, rather than just having do like a huge gesture, but it's impersonal. I don't know how much that helps, but I hope that helps to remember who you are. Is the unique conversation that we had or something, just include a line of that in there.
Thank you for your honesty. Ileana, do you have another one from the chat you want to ask? Otherwise I can keep going.
Yeah, someone had asked, going back to the non-traditional route, they are in the Navy and will likely have to complete some time that they owe for their residency as a general surgery attending before he's allowed to go out and complete fellowship. How do you think that might be looked upon when applying? And I'll ask Dr. Notrika.
One of my partners did a military commitment. Not only did he do his general surgery training, but he actually gave them 5 years of general surgery, and before he went into peds surgery. And he came with some skills that were really valuable. And so there's not much melanoma, and that was no effort for him. He had extensive experience in bariatric surgery, enough that he didn't want to do a bariatric surgery program. I do think that that these people who come from a military background and some general surgery background have a lot to offer. We have favorably ranked multiple applicants who have done military commitments, and I have no reservation about that. And I'll tell you that especially some people who are in the most competitive places in the military, I think they actually get additional points, not negative points.
Dr. Garrison, about when they come by your desk?
Yeah, no, I agree. I think it's only beneficial. I think it's looked upon favorably. I know there were a few people in the match last year with military backgrounds and interesting kind of commitments and passion for pediatric surgery. I don't think all of the programs are necessarily equal, so it's hard to kind of say, but I no one's going to certainly hold it against you if that's what the applicant is concerned about. It's only favorable. And we appreciate your service for sure.
Okay, we have a Canadian question. So Dr. Puliganda, you're up here. Applying as a Canadian resident, is USMLE mandatory to secure an interview in the States, or is it only required to attain visa? You have any input for our Canadian applicants?
Yeah, I think it's always a good idea to apply and to complete the USMLEs. I think it's not absolutely necessary. I can't speak for American program directors. I certainly don't look at that in the screening process. But certainly when you're applying for your visa, if you get matched to an American program, then absolutely they're necessary. So I would just do it if you have the opportunity.
Great. Okay. We have a few more in here. Let's see. Okay. How is post-residency research viewed? I have noticed a lot of research fellowships are geared towards kind of that mid-residency time. But what if I do research after I graduate? Is that, what impact does that have? Dr. Notrika, any comments on that?
So you have to do the math on that. And so if you are finishing your training and then going into lab, it's going to be a long time before you have publications to show for. And so the reason that people go in after their second year is so that the runoff period is such that they actually have the publications by the time they go. I think if you are starting your research career after general surgery training, it's definitely a disadvantage. The other thing that factors in is where are you doing that research at? And so did you just set up shop right where you were doing your training, or did you go to some place that your research may really move the dial? So did you do something that is so impactful to pediatric surgery that it can't be ignored? But I think short of that, I think the time to do it is during your general surgery training.
And Dr. Garrison, you said there's lots of fellowships, obviously at Cincinnati, people doing kind of gap years and filler years. Would you agree with that?
Yeah, I do. Yeah, definitely. I agree with him. I think a lot of those it just seems a lot less common to do this at the end of residency, because then you do have at least a 2 or 3 year commitment until you're starting fellowship. But I don't think anyone's going to hold that against you either. It's just that it's more common to do some kind of fellowship or research in the middle and then start fellowship after. But yeah, our subspecialty fellows are all different. They're all successful in different ways and have different goals. So I agree with everything Dr. Notrika said.
I will amend my statement to say that's the way to get the fellowship. I'm not sure that I believe in it. I really think that we could figure out a better system as program directors where we met the needs of the field of pediatric surgery, the patients in pediatric surgery, and the people who are going into pediatric surgery better by a much more coordinated system. But in 2021, that's kind of the system that we have. I would love to see the fellowship restructured in a way that it was all inclusive, but that's not where we're at.
Let's go back to interns. We've got a general surgery intern who wants to grow up and be one of us. They're wondering what types of things can they do during their rotation that can really make them stand out. And we'll go to Dr. Badru.
So I think as an intern, rotating on the pediatric surgery service, pretty similar to rotating on any surgical service when you're there. Is just work hard, learn as much as you can, read about the things that you want to. All of those things come through. It is nice to express interest, but I think much more so than expressing interest is actually your actions speak to the people around you that, this is something you find interesting, this is something that you find exciting. And I think, at least from an intern level, is what you want to do on your rotation. Now, we talked about mentorship. and we talked about positioning and things like that, you can also use that time to identify some mentors that can help you through your pediatric surgery process. But I think from a what should you do in the rotation standpoint, should just be you doing what you should be doing, which is working hard, and that should show to the people around you.
Great. I think our 30 minutes is almost up. Someone correct me if I'm wrong, but I want Dr. Ghaffar to take it out and kind of give us some important links for the students and residents that are watching. But I just also wanted to thank our panelists for your participation. It's been fantastic. And I think we answered almost every question that I saw in the chat. So Dr. Ghaffar, you can take it away.
Thank you for everyone who showed up, all the residents and medical students submitting your questions and joining us live. We have a number of resources that you can access, and we're going to post in the chat a link to our PedSurg library, where it'll look like you have to log on and you have to have access, but you don't. If you look on the left-hand side, that's where you can access the resident and student section, and there's a handbook and tons of information. I'd say as a pediatric surgery total package of people, we really put out there a lot of content. So it's easy to access in many sorts of different ways: videos, podcasts, good old-fashioned reading. So that's going to be out there. And then we invite you also to join APSA. It's free for medical students and residents. And if you're interested, we're also going to post in the chat that we're recruiting to join some of the committees. And that's a great way to get involved and get your name known and start networking, as well as get a sense of who's in our APSA membership. So we thank you again for coming and look forward to seeing you all in the future.